Hello everyone. In this module, we'll discuss about the medical management of Parkinson's disease. Now, Parkinson's disease is such a common neurological condition, and it is very important for you to know how to manage Parkinson's disease properly. This discussion will be purely a patient-centric discussion, and the most important clinical points to be kept in mind by the clinician while treating Parkinson's disease patients in routine practice will be discussed in this module. Now, first and foremost, when you want to treat a patient with Parkinson's disease, it is very important that your diagnosis is correct. Now, why do I say this upfront? It is because there are often certain pitfalls that can happen while making a diagnosis. So what are the potential pitfalls? Number one, essential tremor. So it's not uncommon that, say, a 55-year-old patient comes to you with bilateral tremor. So on seeing the tremor syndrome and looking at the age of the patient, you might make a diagnosis of Parkinson's disease. But remember, patients with essential tremor, they usually present with symmetrical bilateral tremor. They present with symmetrical bilateral tremor. Whereas Parkinson's disease, if you see, Parkinson's disease, the tremor in Parkinson's disease to begin with is unilateral. And when the tremor becomes bilateral, remember, it is bilateral and asymmetrical. So the tremor started on which side? There you will have more predominant manifestations even when it becomes bilateral. So it is not going to be a bilateral symmetrical tremor in Parkinson's disease. And not just that, in essential tremor, you are unlikely to have any other extrapyramidal features. So the patient will not be having no rigidity and there is no bradykinesia. So this is a common misdiagnosis, that is patient with essential tremor being misdiagnosed as Parkinson's disease. And what is the pattern of inheritance of essential tremor? There is often a family history in almost 50% of patients, and it is usually an autosomal dominant pattern of inheritance. Very important. Now, next is drug-induced Parkinsonism. We know that commonly antipsychotics can produce drug-induced Parkinsonism. And here again, the choice of words are very important. See, suppose you are getting a consultation from a patient who is under the follow-up of a psychiatrist and he is on certain antipsychotics and he has features of Parkinsonism. And when the patient comes to you, you elicit the drug history as well, and you find that this is most likely an antipsychotic induced Parkinsonism. You should not be using the term Parkinson's disease for this patient. Sometimes what can happen is when you communicate with the relatives, you might tell that he has got Parkinson's disease. Remember, it's not Parkinson's disease. It is drug-induced Parkinsonism. So the term Parkinsonism and Parkinson's disease, you should not actually confuse between them. So any patient having features of bradykinesia and rigidity, you would say that he is having Parkinsonism. And when it occurs due to the specific Parkinson's disease, that is your idiopathic Parkinson's disease, it's a different term. Remember, Parkinsonism can happen with other conditions like secondary Parkinsonism, atypical Parkinsonism, or the Parkinson plus syndromes, as well as various heredodegenerative conditions that can result in Parkinsonism. So drug-induced Parkinsonism, important because, and how is it important routine practice as well? We know that if it is a case of antipsychotic induced Parkinsonism, in most but not all cases, the condition can reverse on stopping antipsychotics. In some rare circumstances, the Parkinsonism can persist even after you stop the antipsychotics. Then you've got the atypical Parkinsonism. So atypical Parkinsonism happens with the Parkinson plus syndromes, and it is very important to elicit, ask for the history of the plus features. The plus features are very important. So what are these plus features in atypical Parkinsonian syndromes? If the patient is having an early dementia with prominent visual hallucinations, you will think of dementia with Lewy bodies. If the patient is having some cognitive impairment, along with that vertical gaze palsy, history of recurrent backward falls, you will be thinking of progressive supranuclear palsy. If the patient is having features of significant autonomic dysfunction, you will think of multiple system atrophy. If the patient is having asymmetrical features suggestive of cortical and the basal ganglia degeneration, like aphasia, apraxia, then cortical type of sensory loss, alien limb phenomenon, dystonia, myoclonus. So all this in constellation, you can think of corticobasal degeneration. And remember, majority of patients with the atypical Parkinsonism, they are usually having symmetrical Parkinsonism. Okay, with the exception of corticobasal degeneration. Usually, atypical Parkinsonism is symmetrical, whereas idiopathic Parkinson's disease, or the PD that you can call it, Parkinson's disease, is usually an asymmetrical Parkinsonism. Okay, asymmetrical Parkinsonism. Then you can have vascular Parkinsonism. Following cerebrovascular insults, you can have Parkinsonism. So such sort of a Parkinsonism will be predominantly a lower body Parkinsonism. Important. It affects lower limbs predominantly. So it is called a lower body Parkinsonism. That is your vascular Parkinsonism. Okay. So these are the common pitfalls that can happen while you make a diagnosis, and that is why I wanted to discuss this upfront.